A board workshop of the Board of Trustees of the McAllen Independent School District will be held on Monday, November the 7th, 2022, beginning at 5:30 p.m. inside the Dr. Ricardo Chapa Boardroom at the Administration Building of the McAllen Independent School District, 2000 North 23rd Street, McAllen, Texas 78501. At this meeting, there may be discussion by the board on the items and subjects as listed as followed. 1, call the meeting to order. 2, public comments. There are no public comment speakers listed for today. Item number 3 is the report regarding medical and pharmacy plan. Dr. Gonzalez.
Yes, sir, Mr. President. The district sponsored a self-funded medical and pharmacy plan, and the district's third-party administrators, Blue Cross Blue Shield of Texas, Araya RX, will be presenting their program information, and this item is for information purposes only.
Thank you, sir. So we'd like to bring up our folks from Araya to the table up front, and we can start. Araya?
It's up to you, Andy. Andres, Guadalupe.
Silva?
Here we'll just do, here you go, and just do the.
Thank you very much. Almost took me out. You're all
Thank you for having us today.
Yes, sir.
My name is Patrick McLaughlin. I'm the president, one of the owners at Araya. I think some of you met me before when we made a presentation a few years back. I have with me tonight Chris McNeil, our director of clinical programs, also the main contact for the school district, the day-to-day contact. So we're going to go through a presentation. Normally we make these to the internal staff, so we've done this same presentation, the same format a number of times. We walk through the same process as we go through this. And so I've done this a number of times. I've actually been in this business for a long time, so I've done a lot of these presentations. If I mention a term or an acronym that is not clear to you, please feel free to stop me and have you explain it. I enjoy talking about these things. Sometimes I go a little faster than I should, so feel free to slow me down and ask me any questions you want as we go through the presentation. We're going to start out with plan performance. I'm going to go over this. This is just the raw numbers, kind of showing you where the plan stands from a financial perspective. Chris is going to talk about utilization review, get more into the specific drugs that are being used to treat the disease states and symptoms of the members in the population. He's going to talk about the international pharmacy program that we started over a year ago, and the change is going to happen there. And then we're going to talk about a new member app that we're rolling out to your membership on 1/1. And then there's some supplemental reports that we can get into as well if you'd like to talk about those in particular. So going through plan performance, you have these reports in front of you, right? So you can see these smaller numbers. This is a report that we show, again, with Mr. Silva and his staff. Every quarter we go through this report. And I like this one because it shows the basic metrics that we have to look at to see how the plan is performing from a financial perspective. So in the far column on the left-hand side, you see the different months going back 12 months. We're doing a quarterly report. We show the last 12 months, running 12 months. If you go across the top of that report, plan pay is actually what we billed you, what we're paying the pharmacies for the prescriptions that have been dispensed. Patient pay is what the members are paying, their component of it. Araya's admin fee is listed in here as well. What the rebates are, we're getting back from the drug manufacturers. The international pharmacy program, we're spending there month to month. And then net plan pay. The net plan pay is the plan pay plus our administrative fee minus the rebates plus the international pharmacies. That's the net of what McAllen ISD is paying. Then we give you the member months, or how many members are enrolled in the plan, so we can normalize the data and give you, a factor that you can do some comparisons to see how it's tracking month to month. We call it dollars PMPM, or dollars per member per month. And so as you see that, you can see where the plan is going. There's some fluctuation there. A lot of that is seasonal. There's a couple of things, some decreases we're seeing, increases and decreases we're seeing towards the end of this report that Chris is going to get into in particular. A couple of things that I wanted to point out, if you look at the rebate column, if you look down there, you see that number is holding pretty steady. It started to jump up towards the end as well. I'm going to talk about why that number is getting bigger and some successes we've had along those lines. We look at the actual quarter-to-quarter numbers. We look at the third quarter of 2022 versus the third quarter of 2021. Again, this is a standard format that we go through with the district every quarter. The total plan pay, what the plan's been spending, it's up about 7% over the same time period. As we look at those reports, we saw a big jump in the number of claims. Initially, we thought, what's going on there? But as we looked at it, it's mostly vaccines and antibiotics, which is high in that quarter as compared to last year. If you go down farther, you can see the average prescription price. So we're filling more prescriptions, but the prescription price went down. So less expensive prescriptions, but there are more of them. So after looking at that, we don't really see a need for concern there. Member amounts stayed about the same. Your dollars PMPM, though, our critical number is up about 11.8% quarter to quarter. However, we see a lot of things that are changing that we think, again, this is, 1 quarter out of the year. We see some things are changing that are going to bring that number back to where we were last year. Any questions on that report there? Some of the things I'm going to talk through for a few slides here that are influencing that last report I showed you. Something that we look at again every quarter: inflation and anomalies, things that are driving it. They're kind of out of the district's control. The first thing is just inflation. The drug manufacturers raise their prices a couple times every year. We go back and because we have the history of the drug prices, we can look at medications that were filled in this quarter and see what were the prices of those medications, the list price was a year ago. So we can say how much the manufacturer raised their prices. Mostly, we see inflation on brand name drugs. We've broken this out into 2 buckets here: brand name specialty and brand name non-specialty. Chris is going to kind of explain what that differentiation is, but you can add them all together. That's all the brand name drugs. What we're seeing on that brand name special or non-specialty is about a 3.8% increase year to year. That translates in hard dollars to about $147,000. So those drugs, if we had filled them a year ago, would have cost us $150,000 less. In brand name specialty, about 5.6%. Again, about $150,000. The generic drugs are pretty much staying the same. Not a big increase there in terms of cost of the plan. You see a little bit of a decrease. There's also some new drugs to the plan. So these are meds that we had not seen before, probably new therapies that are out there. People have switched from an older therapy to a newer therapy, about $340,000 in that. It's not a true increase. Some of the drugs are replaced to get that, but there are always new drugs that are popping up in the plan. So the total increases we're seeing from these inflation anomalies about $617,000. But the manufacturers' increases in their price increases accounted for $275,000 of increase. So if the same drugs were filled, last quarter they were filled, this quarter a year ago, about $275,000 in increases. If I put this number in here, so I've got to go back, but if you did look back at that last report, we saw about a $107,000 increase from Q3 2021 to 2022. So there's $275,000 increase in just inflation, but we only saw $107,000 increase. The reason that we're not seeing that full $275,000 in increase is because the programs that we've put in place, along with Mr. Silva and his staff, the international program increases, rebates, and things like that have helped blunt those manufacturer increases. But those drugs are going to keep going up. We're going to keep seeing higher utilization, so we need to keep looking for new ways that we can help reduce the cost to the district as we provide this benefit for the members. International pharmacy is one of the things that we've been looking at, and we've been pretty successful in that. I showed you how many dollars are going through the program right now, but there's still a lot more opportunity out there. This looks at prescriptions that were filled in the last 10 months out of this year that could have been filled through the international program. So about 254 members got prescriptions filled, about 1,100 prescriptions over that time period. Those domestic costs on those are about $1.6 million. The rebates that will be generated on those drugs is about $500,000, $516,000. The members are paying about $34,000 on those drugs. So that net cost to the school district is about $1 million on that 1.6 after rebate and member pay. If we pushed all those medications over to the international program, it would have cost the district about $602,000. So there's a $473,000 opportunity over those 10 months. And so that's what we're trying to go after with the rollout on 1/1 of the mandatory program, taking all these meds and moving them over to the program as well. From when we started this back in January 2021, we saved about $837,000. So that's over, that 20 months or so. Over the next year, we'll add on top of that 837 another about $500,000 as well. So there's a lot of opportunity. Again, we know because we've seen those prices go up, we need to keep working on finding ways to lower those overall costs.
May I ask a question? May I ask?
Sure, of course.
Do we get rebates from the drugs sold in Canada?
No. What if we so?
Most of this chart says.
No, this is the rebates that we're going to lose.
My
Yeah.
bad.
No, that's okay. No, it's okay.
Okay.
We get asked, when we do these programs, we get asked a lot, well, what about the rebates? And you have to net it out because there are significant. Chris is going to talk about how we determine what drugs are actually gonna be filled, and he's gonna show you how we factor that in.
And we've talked about that before, and that's one of the questions I had. Okay, go ahead.
Do you mind if I piggyback on that question?
Not at
On
all.
rebates. Who absorbs the rebates? Is it the district and your company, or
We-
is it just?
We pass 100% of our, of the savings back to the district. Any rebates we get, everything goes back to the district.
100%.
Yep, we don't make any money on the rebates.
Okay, so just so I know this, so the rebates will no longer exist on those specialty, international, well, on the specialty drugs because we're going international, right?
Yep.
So do you benefit from it? Do you receive anything from, and I just.
No, it's a perfectly fine question, no.
Do you receive any kind of benefit or anything from it going international?
No, actually, so what we try to do is stay out of the distribution business. So we don't even charge you an administrative fee on the ones that go through international, because the international pharmacy is actually billing you directly. So I lose a little bit of money. Our admin fee is nominal compared to the cost of these drugs, so the 1,000 prescriptions that we're losing is not a big deal in terms of our total compensation. So we lose money when they go through there. But what we're trying to do, is the right thing for the district and get you the best pricing we can. We want to keep the business. So, no, we're not making any money on the international.
Very good.
And he brought up another question. Do the Canadian pharmacies get paid more, less, or the same as the American pharmacies in terms of gross profit?
Oh, I honestly, I don't know what they're paying. So there's the company ElectRx is certainly making money to administer the program. I'm not sure what the difference is between what they're charging the district and what the pharmacies are being paid. I know that the Canadian pharmacies are really happy to get the business, so I think they're actually making more money filling these prescriptions than they would be filling in Canada. But I don't know, trying to compare what their margin is compared to the American pharmacies, I don't know.
All right, thank you.
Yep. I keep hitting the wrong, there we go. The rebates, so we're talking a little bit more about this. There's also a vendor that we use to help us get rebates for the district as well. They're called a rebate aggregator. They take a lot of companies like Araya, bring us together, get a bigger population, they can get better rebates back from the drug manufacturers. The way that we get rebates back is we get a guaranteed amount based on these different buckets that are out there. So the rebates only come on brand name drugs, and they're really based on what the volume is. So a 30-day supply of a brand name drug is less expensive than a 90-day supply, less expensive than probably what a mail order prescription would be. It's certainly less expensive than a specialty drug. So they're broken out into those 4 categories. You can see these are the actual rebates that we get back from our rebate aggregator. We had a market check window in 2022. We went out to market again, looked at our current vendor, went to our vendor and 4 other ones. And we saw across the board, even our current vendor had much better pricing going into 2023. So we negotiated hard, we got the best and final, and we actually wound up staying with the current vendor. They gave us the best price in the end. But we actually went back and negotiated with them because they were a current vendor. We said, we want to start this before 2023. So we got them to start in September of 2022. So these 2023 rates you see here actually already started for the district, and that's why you saw those numbers click up in September. And I want to remind you about the way the contract is that you have with Araya. It's what we call full pass-through and transparent. So every time I get a better rate from a pharmacy, that automatically goes back to the district. You don't have to recontract with me and get that better rate. If we get better rates on rebates, that automatically goes back to the district. So in the middle of our contract, we got better rates, and we immediately started passing those back to the district. It's one of the benefits of working in a situation like this. I like doing it. I think it aligns our incentives better. And we're constantly looking for better pricing. As I go back to we saw your unit cost keeps going up. We got to find a way to keep the unit cost down. So you can see what the numbers are going to be in 2023, 2024, and 2025. We've got another market check built into this contract, so in 2024, we'll look again. If there's better prices, we'll get those better rebates as well. One of the things that we did do as we looked at those different vendors that were out there, they don't all prefer the same drugs. There was one that had a little bit better rates, but they required us to switch a lot of our members over to different drugs. We stayed with the one that we thought was much better rates, minimal disruption, and chose that one as well. So we're not just thinking about what are the best dollars, also thinking about how much disruption it's going to cause. It usually happens a lot around diabetics, the insulins and things like that. It's about 8% of your population. We really didn't want to get a new program for a couple of dollars more and upset a big part of the population. So that's how we wound up staying with the vendor that we currently have.
Quick question, again, on rebates, pardon me for interrupting, but we get the rebates, do we get rebates from all brand name manufacturers?
Not all brand name, most of them we do.
And usually those are the ones that charge more for their brand name, right?
Well,
Because we're getting back some of our money that we'd already paid them?
yes, exactly, but it's
Wouldn't it
not,
make
it's,
sense-
I'm sorry.
I'm sorry, wouldn't it make sense to buy from those that don't give a rebate because their drugs are lower priced?
So the drug manufacturers, what they do is they bundle things together a lot of times. So if you get a rebate from Pfizer, you got to cover all of Pfizer's products.
beat 'em, right?
Yeah, so it's really hard to do, but you know, there are some times where we prefer generics or brands over generics because the rebate is big enough to make the brand cheaper than what the generic is. So when we can get to an individual basis and vet that out, we do that as much as we can. But the rebates that we're generating are about 30 to 35% of your total drug spend. I just don't think we can just walk away from them. It's not part of my revenue stream, so if they went away tomorrow, I'd be happy about it. And if we could just get better pricing, it's kind of what we're doing with international, is we're not getting rebates there, we're just going right to the lowest priced drug.
All right, thank you. Pardon me for interrupting.
No problem at all. So kind of summary of these changes, there's big increases in rebates. I didn't give a total number here because it's going to be, you know, kind of this switch from international or from domestic to international. So as we go to international, we're going to save more money, but our rebates are going to be reduced. So to say we're going to make this much more in rebates, you know, then we have to go back and change it when we move people over again. But the rebates are up about 40% over what we were seeing from 2021. So we'll get, for the ones that are filled here domestically, we will get better rebates than we're getting now. Mandatory Elector X talked about this, about $470,000 in savings for the first 10 months of the year, about $500,000 annual increase there, just over what we're doing already. And then they talked about some changes that we saw in August and September. There's a number of high-priced therapies that Chris is going to, you know, there's individual members taking very expensive drugs, and some of them have either moved out of the plan or had their therapies changed. So some big changes there, about $38,000 a month in those therapies that have been discontinued for about $463,000 a year. So that's why we're pretty confident that one blip from this quarter, 2022 to 2020 to 2021, I think that's going to probably be eliminated. We'll see a really good full 4 quarters when we see the end of this year because of those few changes there. I'm going to turn over to Chris McNeil. He's going to walk through some of the, sorry.
Before you move on, who is FarmPix?
FarmPix is our software vendor that actually has the adjudication platform that we use. We also use their pharmacy network. So the contracts with the pharmacies are with FarmPix.
Okay, and who contracts with FarmPix?
We do.
You do.
Yep.
And who does FarmPix contract with
In what way?
to get to the local pharmacy?
They have direct contracts with the pharmacies.
Through the pharmacy?
FarmPix has their own contracts,
Or
yep.
through PSAOs?
Well, some of them are PSAOs, yep. Some of the independent pharmacies are PSAOs. They have direct contracts with the chains, then contracts with the PSAOs for the independents.
And the acronym for PSAO?
Pharmacy Service Administration Organization. So it's actually, the independents get together and contract with different processors like FarmPix, so they can have some control as well. They're better off if they can bond together. Actually, independent pharmacists are disadvantaged. They're really not allowed to get together and say, we're not going to take this Blue Cross plan, we're not going to take FarmPix. They have to do it through another organization. So they're kind of hamstrung, the independent pharmacists. They don't have as much control over their contracting as, say, you know, a CVS with 5,000 or 6,000 pharmacies who just has one contract.
They're the lowest part of the food chain, right?
Yes, they are. Yeah, they get beat up a lot.
You say that all you want tonight. Thank you.
You're welcome. Ready for Chris? I'll let you go.
Thanks, Patrick. So the first part of the presentation dealt with the raw pharmacy spend, the raw numbers. What I'm going to look over now is the therapies being used, the changes to those therapies, and how they are going to be impacting the McAllen pharmacy spend going forward. What I want to look at first is brand and generic claims. Starting from the top left, the claim count by brand and generic. The gray area is what I want to focus on, the single source brands. These are brands with available generic medications. I'm sorry, these are brands with no available generic alternatives. These are taking about 15% of the claim count for McAllen. If you look on the top right, the cost, the same gray area here is a much larger piece of that pie. So what we're seeing is about 15% of the claims are taking up 84% of the costs for McAllen. What Araya does is we focus on finding savings for these single source brands or brands with no available generics in order to make the biggest impact while impacting the fewest number of people. And just some background, the single source brand medications are medications you see advertised on TV, your Trulicity, Ozempic, Rybelsus. It also includes specialty medications you see like Humira and Enbrel. So it's anything you see advertised is you can consider a single source brand. So we're looking at targeting those to reduce the plan spend going forward. These are the medications. These are the top 15 specialty medications. And when I say specialty, specialty medication is a medication that requires special training, storage, or distribution by the pharmacy or the prescriber. They could also just be very high-cost medications. Working from the left to the right, they have the medication name and then the group or indication it belongs to. And then the green bar and the information underneath it is the data from Q3 of 2022. We have the current utilizer count, the claim count, member paid and plan paid. And then the same information is under previous, the gray bar on the right, that is the information from Q3 of 2021. So what we're seeing for McAllen as well as all of our plans is an increase in utilization of drugs like Humira, Enbrel, Rinvoq, and Xeljanz. These are medications used for inflammatory disorders or autoimmune disorders like Crohn's, ulcerative colitis, rheumatoid arthritis. Pretty expensive medications indications to treat. McAllen also saw 2 new chemotherapy medications which are costing a bit of money. Imbruvica and Verzenio were not on the claim history for Q3 2021 and are now, and they cost collectively about $60,000 every quarter. I've marked the medications available via specialty pharmacy with a golden star to show savings opportunities going forward. The typical discount for any of these starred medications available internationally is about 40%. And if you look at the utilizer count for each of these medications, we see a lot of 1s and 2s and 3s. So what we can say is that if we target only a few number of drugs, few number of members, we can save the plan, we can save McAllen a lot of money going forward, because each of those drugs is looking at like a 40% discount when it's filled internationally. Excuse me. The slide is showing the top 15 members by plan paid. Patrick mentioned before, there were some disenrollments, some significant members that were disenrolled from the plan. These are marked with the red circle and the slash to them. These will not be ongoing costs for the plan, so we do see some significant drop-offs here. The starred members here have at least one international medication, so again, significant savings will be realized from those when they start using international pharmacy as of January 1st, because that is when it is becoming mandatory. We'll talk more about that in a minute. Collectively, between member discontinuations, rebates, and an international pharmacy, we're expecting to save at least $50,000 a month for the McAllen pharmacy benefit, which is $600,000 a year, which is about 11% of the pharmacy spend. Let's talk at this time about international pharmacy specifically, and how the process works, how we pick what medications are on the international formulary. We receive an initial list of medication strength combinations, about 600 medications and their strengths. We reduce that number. We look at the medications, their unit cost, and the rebates associated with those medications to make sure McAllen's only sending things internationally that they're going to save money on. If you're going to save money domestically, we're not going to send it overseas. So we look at this every quarter. At the end of this analysis, which we run quarterly, we have about 200 medications left. Yeah.
Are you the gatekeeper on that?
Yes.
So the claim goes to you first?
So the process works. Right now, all these medications that are available internationally are under prior authorization. So, like our normal process for prior authorizations is that our account services team collects medicals from the prescriber. We don't use services like we don't use.
I know what you're talking about.
Yeah, we don't rely on a third party. We look at the actual medicals from prescriber. we go through, making sure the diagnosis is correct, the duration of the therapy is correct, the quantity is correct, and all the things are lined up. If it's approved, then it goes to, it gets filled domestically. After 2 fills, after a fill the first time, we send a letter to the member saying, your medication will be required to be filled internationally after 2 fills. And we'll give them information to give to the prescriber to make sure that that transition is smooth.
So internationally available drugs are flagged by you, you pull them out, and then you make contact.
Yes,
Got it.
that's
Okay,
correct.
Thank you.
Based on January through October claims data, this is showing the top opportunities for McAllen by claim count. You'll note here there are some some duplicate drug names on here, Ozempic here twice, Trulicity here twice. These are different strengths. We do review each strength independently because the different drugs have different ingredient costs. This is top opportunities by savings. And again, we're going to see the same medications we've seen in previous slides that are costing the plan a lot of money, the Humiras, the Enbrels. We are, excuse me, sorry. Do we have any questions on the process for international pharmacy, how it's going to work for the members? As of January 1st, we are doing this to be mandatory. We are expecting to see significant savings. If members are not going to be utilizing and have not signed up for Electrox, International Pharmacy, we'll make sure that they are contacted again and that everything's smooth. We want this to be as flawless as possible since this is a pretty impactful initiative by McAllen. So this will go smoothly, making sure of that.
In the event that there is a hiccup, who would be our contact person?
Me,
That'd be you, Chris?
yeah.
Okay.
Yep. I'll facilitate communication with Electrox. I'll take care of McAllen, I'll take care of the member. For any scenario where the member might miss a dose, we will make sure they get the medication domestically. Even though there's cost savings for the plan internationally, the member's health is important as well. So if they're going to miss a medication dose, we'll make sure they get it filled here. It's just as an interim between getting it filled here and getting it filled internationally.
Is there anything that our members can do ahead of time to prevent a missed dose?
Yep, the letters that we send out after each fill have all the information of what Electrox is and what a national pharmacy is. At the end, it has instructions for what to give to the prescriber, and it recommends having at least 3 weeks of therapy on hand before the process of transitioning that to international pharmacy starts. So I guess just due diligence of making sure you have enough medication on hand, like it says in the letter, we'll make sure that they have enough time and they don't miss a dose.
And how is that letter marked when it comes in with the prescription? Because when I get my prescription, I see all the instructions and it goes out the
no, no.
window,
I
and I just take my bottle out and I'm
Mine
good to
too,
go.
yeah. It's
So I want to make sure that when our members receive this, that it's not
it's-
just something that they discard.
It's a, sorry.
You're-
It comes
It comes from the district,
It's got a
okay.
McAllen stamp on it.
Good,
Yeah.
okay. Thank you, sir.
No problem. At this time, Patrick's going to talk about Clara and the new member engagement tool.
I do have one question. I probably should ask this in the beginning.
Yeah.
There was a clause or there is a law that changed to allow us to use international pharmacy, and I'm going to tell you already, I don't know enough, and I'm trying to do a little research. I'd rather ask you to see if you know the answer. Where this is window for allow us to get our prescription, save money. Is it open for a couple years? Is it open for, is there any dialogue on that or any chatter?
So, it's a non-enforced regulation right now. What they say is, you can go and get medications for what they call personal reimportation, for personal use. So the same way you could go across the border and buy things in Mexico, it's the same thing, as long as you get it for personal use. That's why it's set up so that it goes directly to the district and the member signs off and lets them bill on their behalf. It doesn't come through Araya, because that becomes facilitating reimportation, which they might come after us for. So that's why it's set up that way. We've seen a couple of letters from the FDA in different cases. They say you can't do this, but then at the end of the FDA's letter, it says, none of this should be construed that you've broken any laws. So I don't know that they're monitoring it, but right now there's no signs on the horizon that they're going to stop this from happening. If it does get stopped, it'll be the drug manufacturer saying, too much, we're losing too much profit, we can't do this, and obviously they have the biggest lobby out there. But we've been doing it, we've had groups been doing this for 10 years, so it's been going on for a long time.
And just to follow up on that, and the pharmaceutical companies also, they, whatever adherence in the United States is also in Canada, right?
So the way that ElectRx chooses the locations where they allow things to get filled, that country has to have the same kind of chain of custody, chain of control that the FDA has here. So they call them Tier 1 countries. I don't think that that's a U.S. term. I think it's a term that ElectRx and a couple others, they use this term Tier 1. But when you look at, it's coming from New Zealand, it's coming from Ireland, it's coming from Canada. It's not coming, from North Korea or places like that, So we're real confident. And I've done a lot of vetting of, we have two vendors that we work, like ElectRx has a broader selection. There's a company called CanRx that does as well. I've vetted them out quite a bit, and they're very conscientious about as they make these selections and stuff. So they're just going to places where I would be comfortable getting medications from.
Awesome, and just a comment, I have a family member using y'all, and y'all help with the process of getting the prescription, getting, walking them through, and answering all the questions, so very helpful on that, so thank you.
Great to hear.
Thank you. I think I don't know if we're bumping up against time here or not, but I just want to go over, on top of, are we still okay?
You're good.
So we're rolling out a new tool that kind of dovetails in with the international program. It's called Araya. It's an app. It's a digital member engagement tool. We call it your virtual pharmacist. So we're using an application that was built by their company called LeverX. LeverX built the initial version of this. They've deployed this to some big plans, health plans with 300,000 or 400,000 members, are actually using this application to help their members navigate their pharmacy benefit. We white labeled it as Clara, and we've added some additional functionality to it, and that's why we're calling it that. There's really three areas of focus that we have as we roll out this plan. The first is convenience, giving the member more information, through a mobile app where they can start asking the questions that they need. The second is a sense of consumerism. We don't think that the members actually know a lot about how much the drug costs. They might know their copay, but they have very little information about what the plan is paying. So it's going to include both those pieces of information. And then there's a lot of customization that we could do around in terms of sending messages out to members. With the international program, if they get a prescription that's filled internationally and using the app, they're going to get a message that said they could have done this internationally as well. We can also do a whole bunch of things around wellness and other health initiatives to get the members that information. The ways to contact the member we don't have today. In terms of the features within the program, it's going to have the pharmacy network in there for the members to access. It'll have their total medication history. It'll have what the formulary tiers are. If there's any prior auths, as Chris was talking about, or step therapies or quantities, exclusions, things like that, that'll be listed in the app as well. It'll show lower cost alternatives of what the members getting filled today, both for them and for the plan. It'll allow them to make switches within therapies or within pharmacies, and also the custom messaging I mentioned before. In the next version, we're looking at our roadmap is actually having an ID card for the members. So they have their at least their Araya information for billing in the app as well. And then we're trying to build in some PA notifications. So if they are waiting for a PA, we can give them messages through that as well. Kind of the benefits for the member is not just knowing I can go to CVS, but knowing when that CVS is open. So all the hours and functions that CVS posts online, that's in that app now as well. They can quickly find the meds that they're prescribed. We've all been to, a medical provider, and they ask, what drugs are you on? If you're lucky, you've got a short list, it's easy. But a lot of people have, 7 or 8 drugs. Now they have all that information for them in their hand. What the kind of questions you ask when you go in the pharmacy, is my drug covered? What's my copay going to be? Are there less expensive alternatives? Those things are in the app as well. So if the member's at the doctor's office and the doctor writes a new prescription, they can go in and put that claim, that drug in. It actually does a test claim against our system. So it comes back, says, here's what your copay would be if there's any PAs on it, or there's less expensive alternatives out there. So it'll tell the member, even before they're in the pharmacy, what their costs are going to be, what the plan's going to pay, and what the alternatives are. If the member if they're on a drug and we send them a message saying it's a less expensive alternative, they can kick off a fax to their doctor's office and say, hey, I want to switch to this medication, can you contact me? It'll also, if they want to switch pharmacy to pharmacy, it'll kick off a fax to the pharmacy that the patient wants to move to, as well as the doctor who's prescribing the prescription. We think this is going to help a lot with the ElectRx program, because, as we said, the member's going to get the form in the mail saying, here's what the information that ElectRx needs. Now we'll push that to them electronically if they take advantage of the app. So I think there's a lot of functionality within the app.
I got a question just on that,
Yep.
because I have a college student, she used an app. And I realized that maybe.
One or two.
Maybe I didn't have the right insurance, but, in that app, is everyone's copay, so like, any employee here, they punch in exactly what you said, their medication. Is it gonna tell them, well, it's cheaper or less expensive, your copay at a certain pharmacy versus another one, or is everybody the same copay?
Well, let's say it's a brand name drugs, your copays are the same. When it gets to be generic, the cost might be below what your copay is. So, again, we talked before about the way our contract works. You actually see what we're paying the pharmacies. And we have different contracts. FarmPix has different contracts at different pharmacies. So sometimes, CVS or Walgreens might be, $30, for a generic cholesterol pill. But, another, Walmart might be selling it, at a low cost of $4. They'll be able to see what those different prices
So
are.
my question is,
So, yes.
that $4 contract, why don't we have that for everyone?
Well, it's what we contracted with the pharmacies. And so what happens is, not to get too deep in the weeds here, some drugstores, they want to give away their generic, so you come in and buy the brand name drugs. So the brand names are more expensive, but the generics are cheap. Other ones are the other way around. They'll give us a real deep discount on the brands, and they'll get a cheaper, or a higher price on the
The
generic.
reason why I asked that question is that I would like for everybody to be on the same playing field, right? If my insurance is driving me to go to a certain pharmacy, then that means that there's money involved on why they want me to go to that pharmacy.
Yes.
So I think there's 9 other pharmacies that are at a disadvantage. The other example I'll give you is my daughter used our insurance at a CVS, and the pharmacist told them, well, don't go through your insurance. It's cheaper to go through something like this.
Use GoodRx.
So I'm thinking to myself, well, why do I have this insurance?
So, well, was it our card?
I'm not gonna tell you.
No, no, so, no, but,
No, I don't, we're not employed in the district.
No,
but
no,
My
but-
whole
but-
point is that sometimes it's less expensive not to use your insurance. I'm just like, why?
So, what happens is, and again, one of the reasons that I think Araya is the right company to work with is we pass you back exactly what we're paying the pharmacy. So there's no, what they call spread built in, where I pay the pharmacy $5, but I charge the plan $15 and make $10. What happens in those situations is, your daughter has an insurance plan, and the insurance company is not watching what the PBM is doing, and they're letting the pharmacy bill up to that $30 copay. So even though it might cost the pharmacy $2, they're saying, oh, you got a $30 copay, we can charge you $30, and the PBM comes back and takes part of that $28 in between. We don't do that. We pass back whatever our discount is. Sometimes it's really low. We have different prices at different pharmacies. Sometimes it might be cheaper, at Joe's Pharmacy, than at Walgreens or vice versa. But you're going to see the actual price, and there's no spread. And even with our contract with FarmPix, we have, our deal with them is we pay what they pay, so they're not making any spread on it either. So that's usually what's happening. The reason GoodRx works is, and GoodRx is owned by Express Scripts, the biggest PBM out there. So what they're doing is taking advantage of these arbitrages, saying, you know what, we're going to do this. We'll offer a different price here, and we'll still make a little bit of money and take it away from the other PBM that's out there.
I'll save my questions for Blue Cross. I'm just joking. That's who I have.
But I mean, those are the weeds, and it's one of the reasons why our business model is what it is, because we want to give you back. We know there's better pricing out there. We know that our price is better than what GoodRx is, but not every PBM offers their real price.
I understood your explanation about the discount. What if a store doesn't offer a discount? And you mentioned a little while ago, you said that the independents were at the greatest disadvantage in this system.
In terms of how they get beat up, by the Express Scripts of the world, because they can't get together and say, we're not going to take your plan.
In our plan, are the chains and the independents paid the same for the same drug?
Not necessarily, no. It's whatever the PSAO negotiated with Farm Picks. And so I can show you, I'll send it to Mr. Silva and say, here's the discounts that we're getting. They're pretty close. We get better rates as some of the, get better rates at CVS. Walgreens is in your network, which is good. Walgreens is got the highest rates. They won't give their pricing away. But we get probably our deepest discounts that we get are from the grocery store chains. They get really aggressive because they want to get people into their stores. But the independents are all pretty much at the same level, somewhere in the middle there. They're not necessarily getting paid more or less. They might get less on generics, more on brands. But I'm happy to, as part of our contract, happy to show you what the rates are.
So some
But
of
we're
the
not,
things-
we're not going after one. We try to get the best price we can from
Sure.
everybody.
And rightly we should.
Yeah.
So some of the chains are paid better than independents, and some independents are paid better than some of the chains.
It could be, yes. You go drug to drug, particularly within generics, because we have MAC prices that we use, and so depending on what your basket of drugs is you're filling, your average discount might be different than what theirs are, just based on the drugs they're using.
And I'm not gonna mention the name, but several years ago, we had an issue with one of the chains. They would not budge on their price, so we excluded them from our contract here. And they finally budged. I don't know why we don't do that today.
We haven't talked about reducing this. One more thing that we could do is, I'll
Put
be happy
everybody
to
in the
share.
same- And let,
I have one more dumb question.
Yeah, none of them are dumb. Nothing
If
so
I
far.
were to give every employee, not me, but let's say the district would just give everybody RX cards, right? Would we lose money if they didn't fill their prescriptions with McAllen ISD's insurance and use the RX card, if it saved them money?
No, I really can't. You mean like the
It
Good
wouldn't
RX?
Save us money?
You mean like Good RX?
it would cost the employees money.
It would be more expensive going to Good RX than it would. I'm really confident my pricing
Okay,
is
no,
better
no,
than
no,
Good
no,
RX.
no.
Because Good RX is making money on
Oh,
the spread,
Everyone's making money.
Yeah, they're paying the pharmacy less than what you're paying, but I've looked at the prices. So we're gonna do a rollout of the app. We're gonna do training for the membership. It's available in the Google Store and the App Store, so it's been vetted by both those major platforms. It's secure, it's HIPAA compliant, and there'll be training. We're gonna put, we'll do some live webinars, and we're also gonna have a webinar on the website that people can go to learn how to enroll in it. We're gonna be pushing hard, a lot of emails from the district, try to get many people as possibly can enrolled in the app. So that's the functionality is scheduled for first quarter, but what we're gonna do is, when people first sign on here, for McAllen in particular, there's gonna be a splash screen, and it says, if you need to speak Spanish, there's a phone number, and we have a bilingual help desk that'll walk the person through. But by the end of the first quarter, it'll be fully bilingual.
Any other questions?
You asking me? No.
Pat, I think we're good.
I'm
and We
good.
appreciate your presentation
Oh, thank you.
and the good work you're doing for us.
All right, thanks for having us.
Thank you.
We'll take it easy on Blue Cross, okay?
Good evening. Board President,
You guys ready?
members of the board.
Danny doesn't want to talk about it.
Well, it's my presentation. You know, Marco, you ready with the questions? 6:30 is right around. You're not leaving? He cannot leave. Okay, good afternoon. My name is Tita, and I work directly with Blue Cross and Blue Shield of Texas. Some of you might know me. And Cindy, my director, is here, and we also have Hobie with us. In case you have any questions, I might not know the answer. They might be able to help me. If not, we'll get you the answer. We'll try. The period that we're going to be reviewing today is just your medical plan review through Blue Cross. And we're doing January 1st through September the 30th of 2022. The benchmark that we're going to be using is the K to 12, and this is state of Texas. And then we also have the Rio Grande Valley, just so we can have an idea. The high-cost claimants, those will be defined over $50,000 that they had incurred, and this will include medical. And you will say in their pharmacy, there is some pharmacy coverage, medication coverage, mainly injections, self-injectables, that they're covered under the plan. And that's why we had that other disclaimer that the total reflects medical claims only unless otherwise specified, and I'll let you know where it is. This is our first presentation to the board. We usually do the yearly, the annual, and that one just takes a long time because we do have more information that we provide. We do comparison, we do recommendation. So today it will be just basically financials. Any questions, please stop me, because once I start talking, it's hard for me to stop. The key indicators in here, it is, how much was paid per member per month. That's PM. That's what it indicates. So under the medical, it's 257. Go ahead. There you go. Thank you. What costs per member per month, and this is including your employees and their dependents. The total paid in the first quarter of 2022 was $4.2 million, and the total claimants were 3,800. On the second quarter, we paid $245.13. As you can see, it went a little bit higher. Per member per month, and the total paid was $4 million. Total claimants, we had 3,600. On the third quarter, it was paid per member per month $286.37. The total paid was 4.6, and the total claimants was 3,660. The total for the 3 quarters paid under your medical was 12.8, versus in 2021 we paid 13.5. The top 3 categories, and we go to the neoplasm, factors influencing the health, which it includes COVID in there, injury and poisoning. The total for those top categories that we paid was $1.7 million. The top 3 for the second quarter was the MSK, factors influencing health, and the neoplasm. Total paid $1.6. That's just on that second quarter. In the third quarter was, again, factors influencing the health, neoplasm, and genitourinary. And we paid $1.8 million. In 2022, for that quarter, on those top claimants, we paid about $5 million. In 2021, we paid $4 million. We have that high-cost claimants, remember, over 50,000. We had 29 in the first quarter, then it increased to 30, and we are at 30. In the first quarter, it was 984,000. The second quarter, 1.1, and the total for the third quarter was 1.3. It's about a 3.3 on 30 claimants that we currently have. In 2021, we had 26, and we paid about the same amount, 3.3 million. Chronic conditions, that is your hypertension, we had 922, and it paid 1.8 million in the first quarter. The second one, it was 912, we paid 1.5 million, and continues with the hypertension, 947, and we paid 1.9 million. We're seeing that is your top chronic conditions that we see, that it's your top one, it's the hypertension. Sorry. Financial overview, you have it by quarter in there. If we focus on the total that was billed, that's 66.9 million. Then if we go to the allowed, which is about the fifth one, and we allowed 17.3 million. And of that, we go to the paid, which is like the fourth from the bottom up, and the total paid was 12.7 million. The network performance, you're getting a 71.4% discount. The discount savings are up to about 36.7 million. 99.1% of the population for McAllen ISD seeking treatment from providers that they're in the network. So it's a very good. So the more that your employees and their dependents seek treatment from providers in our network, the higher your savings. Any questions? Okay. We go to the key matrix, and this is, the first one will be your inpatient pay per member per month. That's IP. Then it goes to the OP, which is outpatient paid per member per month, and the total that was allowed per member per month, and the in-network paid. As you can see, January 2022 through September 2022, the inpatient was paid at 42.43 versus in 2021, that was 81.95. Compared to the benchmark, that's the school districts K to 12 in the state of Texas, they're paying 87.06. If we were to compare just to the Rio Grande Valley, you're still lower than them. We're at 72.70, the rest of the districts. Now, on the outpatient paid per member per month, you can see we have in January the 20 through September 21, it was at 84.11. It increased on January 2022 through September to 104. You're still lower than the benchmark and a lot lower than the districts. On the professional side, it went from 105 in 2022 to 115.53 in 2022. The lower than the benchmark and lower than the Rio Grande Valley. So even though the inpatient paid per member per month showed a significant decrease in paid per member per month compared to the book of business K to 12 and the Rio Grande Valley benchmark, okay? Your outpatient, and that's what you want to see, because we know that the longer they stay in an inpatient setting, the more expensive that it will be. So seeing that there's an increase on the outpatient, it's good. And also on the professionals, at least we're seeing that your employees are seeking treatment from providers. Any questions you might have? No? Okay. Your diagnostic categories. And you will see on the top chart, and it gives you, the lighter blue is your high-cost claimants. That's anyone over 50,000. And you will see in here that your neoplasms, and we'll see how many we have. I'll give you the count on that. And there, where it says health status, that includes your COVID. That's what it is. But it's not spelled out. We just include in there your health status. And you can see that it's followed by injury and poisoning. And your third one was your circulatory. It gives you in there, also we had that complication of cardiac and vascular prosthetic devices, implants and grafts. We have 2 claimants, and you will see. So it gives you other medical care, again, that it includes, but it's not limited only to COVID, but that's what it's related to. Yes, sir?
Is HCC high-cost claims?
Yes. Your high-cost claimant.
That's your, okay.
Yes, high-cost claimant, and then the PMPM is per member per month, and that includes employees and dependents. Any other questions on this slide? We know that top one, okay? Then we go to your high-cost claimants, again, over 50,000. In here, remember that I said we're going to go through 2 on a slide, that neoplasms, that is 12. We have 12 active claimants, and we had paid $1.6 million. And pay per claimant, if we were to divide it among the 12, that's $139,000. This current period, January through September 22, we have 30. The previous year, during the same period, we have 26. In those 30 high-cost claimants for this period, they had accounted for 26.3% of your medical claims. Okay, just those 30 high-cost claimants, they had spent 26.3% of your overall cost. The total plan spent for high-cost claimants was $3.4 million. This 22 period, the previous was 4.3. Compared to the benchmark, they're at 0.52. I'm sorry, McAllen ISD is at 0.51, and benchmark it's at 0.82. And the average plan spent per high-cost claimants is 111,000. Previously was 98,000, so, and it gives you in there that 26.3%, and the benchmark was at 26.9.
You say 98,000, you mean 984,000.
900, yes, ma'am. Any other questions? Okay, we go to the chronic conditions, and in here you have listed your asthma, your CAD, coronary artery disease. We do have your congestive heart failure, and then your chronic obstructive pulmonary disease. As you can see, your hypertension on, let's go to the total on my right. It's, we have 1,131, and those hypertensions have spent 5.2 million. Some of them might be on your high-cost claimants, so all of that, it's included, so this is just what we're doing. So remember that during the interview for the insurance that we said we do have programs that we can implement. Well, we already started at McAllen ISD, and we implemented for diabetes, the Livongo. So we also have that for hypertension, so that might be something that, we might think that that could be your second program that you can implement for your employees and try to help them with the hypertension, because we have seen an increase. And I'm going to say something in here. Like I said, we were put on pause for about 2 years with COVID, and then we started moving at a very slow pace, and now we're moving faster than we were doing. So we started taking little steps now. They're a little bit bigger steps, and we're going to start running pretty soon. So what I will say is, maybe this, the beginning of the plan year, that will be something that we could consider, and we'll coordinate with Mr. Silva and Mr. Miller and see if that's something that will.
Along those lines, and diabetes is our highest cost.
Mm.
Well.
Yes,
and
it is
stay-
very high.
Yes. But we also know that treating diabetes, it's for life, right? And from start to finish, there are places in that lifespan that are less expensive to treat that patient if they follow a certain plan.
Correct.
That should be our priority on those. And the same thing with hypertension. If you can reduce whatever's causing it, et cetera, and better lifestyles, healthy living, all of that, if we can get them into that space and make that space the biggest part of that spectrum, we can lower these costs, right?
Absolutely, we guarantee, and we do, like I said, we already started, it's implemented, it has been implemented for a while, the Livongo for diabetics. Yes, we already have that in place. And that's why they're not as high now.
And I see your posters around the different buildings and things that we have. I see them all over the place, so I applaud you for that. We
Yes.
just need to encourage our people to get into that larger part of the spectrum.
Exactly, that's what we need, to get them to engage in the programs. And that we cannot force, but we can provide the tools for your employees, because these programs are virtual programs that you will have to go into the computer, make the time, and take that virtual course.
Councilman Salas, and the same work to you because, we're self-funded and, when you read the hypertension, what we're spending in diabetes, including in that, if we can come up with some wellness programs or some type of competition, school versus school, staff versus staff, and it's not about, who can do the fastest 2 miles, but whoever just logs a mile or two of walk in a day, right? I mean, whether it's around the street or something, and then they get into some type of competition to, win some prizes. We have community members that we work with that can give some prizes. We come up with something. But I think that might be a good pilot for us to see, because, anybody who's dealt with hypertension and, what I've had about with it, stress, when you're dealing with family, how to pay for college and all that stuff, and you watch, you're eating Whataburger on the road instead of, all the time late at night, it catches up to you. So when you go see the doctor, he's like, well, I can give you medication or you can start taking better care of yourself, and it's me, my phone is me.
Okay, yes, sir.
And so in that particular sense, I decided just to make some changes, right? And at the end of the day, I didn't need that medication, so I didn't need those office visits. I didn't need, but I did have some competitions, and even now when I'll wear my Fitbit because I want to log my miles, and it's not even competition against anybody else. It's just opportunity to win a prize. I mean, so maybe that's something we need to look at to help incentivize, because we got to do something about that number, and I think if we can get more people out walking, just walking, I think it have an impact. So just kind of a little off topic, but not a little off topic, it impacts that, but maybe we can do something, down the road. I don't have a skin in the game, I'm not working for an insurance company or anything like that, I have that experience, and I know it works.
Yes, sir. And I see Mr. McClenny at the back of the room there, who's in charge of physical education, and I know that he has some programs aimed at staff also. I do want to commend our staff. I know the It's Time Texas Community Challenge we've won the last couple of years, but to your point, Trustee Alvarado, we do need to take it to the next level. So we'll continue. I'll work with the team to see what we can do to continue encouraging
There's some
physical
apps
fitness.
that, you can sign up, and so somebody at
Yes.
school, we can even do it where it gets to a certain level, they can waive co-pays, you can do stuff like that, stuff to encourage behavior. And I'm sorry, they can wear jeans on Friday. Oh,
Absolutely.
That's absolutely huge, right? But they log in, 2 miles, 4 times a week, 8 miles, 10 miles a week, they get the opportunity, to maybe wear pants or, what have you. I bet we'll see a little drop in that. So just something to think about. I think we talked about it. There's apps out there. They probably have apps that we can work with them as
Yes.
well. But we just got to have a little more skin in it. And I'll be more than happy to serve on any committee to help fund this as a pilot or something, just to see, right? I mean, I don't want to go out big. I think you got a lot on your plate too, sir, but maybe just us here walking.
I mean, we'll figure it out, sir. I know that that's one thing is we're problem solvers, so I'll get with the executive leadership team and we'll make sure. I know that much is expected of public school educators. I'm lucky I don't have a stressful job, but if I did, I think physical fitness would be one where yeah, it needs to be a key component to moving forward. So I'll get with Mr. McClenny, the entire executive leadership team, and then we'll come back and let you know what we're gonna do.
I will do this. I will put in at least $100 gift card for the first competition.
Okay.
Oh.
All right. Here we go.
There we go. I mean, and I don't want you to, I think the rest of the board, are we okay with those comments? I mean,
They're all in line, sir. I think you're good.
I'm happy to cheer anybody on.
You do CrossFit though.
It's not a competition of who does more miles. It's really just competition of that person just to get moving.
That's right.
That's all it is. I don't compete against anybody else but myself.
Yep. Well, we can look at it from a body mass index standpoint, percentage of pounds lost and things of that sort. I can already see Mr. McClenny's thinking, so we'll be ready, sir.
But I will beat him in miles. I do 100 miles. Not fast anymore, but I do 100 miles.
I want to challenge anybody to
On the board.
He beats me, right?
All right. Now we're getting off topic. Now
Now you're getting out of
Now
topic.
it's getting,
I'm
yeah.
sorry to say.
We're gonna focus
Yes,
back
sir.
on ETA, and we're gonna get back to Blue Cross Blue
Okay,
Shield.
Sophia, they're not taking your challenge, they're coming back to me.
We're coming back to you, ma'am.
They're coming back to me. They already, any questions you might have in here, and no, you were not off topic, and we do have what it's called the Blue Access for members, and that's where members can sign, and there are a lot of programs that they can take advantage of, but they will need to sign in there because there's a lot of information for them, exercises, they can just, get information like from the library, or they can chat with someone, coach or anything like that. So yes, we do have that program available, which is the Blue Access for members. And yes,
I'm sorry, what was the name of that program?
Blue Access for members.
Blue Access for Members.
BAM. Yes, and we have a big populations at McAllen ISD because not long ago, and with those 2 years, I got lost, so I cannot tell you 5 years ago or 6 years ago, there was a health risk assessment that the employees could take and they could bring in and they will get an incentive. It was a few years ago. I don't remember exactly when. Was it McAllen ISD? Yes, it was McAllen ISD. I don't forget. They don't want to
Andres
remember.
Guadalupe is smiling, so I think it may
Okay,
not
do we
been.
have a new name or it is his name?
Andres Guadalupe is his new name.
They just gave him a little name.
No, his real name is
Middle
Andres
name.
Guadalupe Silva.
Just, he's gonna clarify that middle name. Let me get to, I don't want to be against the wall.
Would you please introduce yourself, sir?
I'm sorry?
It all
Would you
started
please
with
introduce
Hispanic
yourself?
Heritage Month, and it's carrying on now.
Would you please introduce yourself, sir?
It hasn't gotten old yet?
It's never gonna get out. You're on the hook for that
Well,
one.
good evening, Andres Guadalupe Silva.
Thank you, sir.
So I'm not sure if she's referring to many years ago when we did have those wellness screening incentives. So yes, that did draw a lot of folks to participate. However, that's not tied into what she's referring to now, which is the Blue Access for Members. That has existed from day one. We've promoted it every year. It's a program where you do have to actively engage. So you enroll, and if you do some healthy activities, then there are some built-in points you start earning. And then they have like a store where you can turn it in for some kind of incentive. So that does exist. It does include things such as walking, those kinds of things. You log your exercise, a bunch of different activities. You can also take advantage of some online modules, and that gives you points. You can take advantage of some courses, that gives you points. Any activity you're doing, you log that in, and that gives you points. And then as you're accumulating points, you can take advantage of that opportunity to turn it in for some kind of a incentive that's on their store. So I just wanted to clarify that part of it. So I'll let her continue, unless you have some questions for me.
Okay, we move on to the emergency room, and these are the total. We do have the total of visits during the 3 quarters. That's 796, and the facility at the emergency room was allowed 1.5 million, and the emergency room facility paid was 1.2 million. If we were to do a per member per month on the emergency room facility paid per member per month, that comes out to 25.86, the average for the 3 quarters. And then we provided only with the 3 top emergency room facilities where your employees and their dependents are going to. That's the McAllen Hospital, Rio Grande Regional, and the McAllen Emergency LLC.
So McAllen Hospital and McAllen Emergency LLC are better known as, is that South Texas Health
The
System?
South Texas Health Systems.
Okay, for both of those?
Yes. But the McAllen Emergency, it is detached. It's an on-site facility. I really don't know where it's located, but the McAllen Hospital has their own emergency room, and then they have a facility like the ones when they started coming out, all those emergency rooms along the expressway, which I drive quite some time. And I will say they're popping up just like popcorn emergency room facilities, and they're very attractive where it says 5-minute, 4-minute wait, or just call and we'll be ready for you. So that's this McAllen Emergency LLC. It's a facility that it's not connected to the hospital.
So this sounds like the one on North 10th that used to be the neighbors emergency?
Could
No?
be, because it is on North 10th. I just don't know what was in there.
Okay, thank you, ma'am.
You're welcome. Yes, probably. Then we go to your top providers, and this is the inpatient facilities, and we provide you the top ones, and by the paid amount, as you can see, that's Rio Grande Regional, your top one, followed by Doctors Hospital at Renaissance. You will see, probably you already noticed, that there are 3 Doctors Hospitals at Renaissance on that report. It is the hospital, the main hospital, and then they do have other, they call them campus, which are other clinics. So they're all billed by the tax ID number, but they're also tied to the facility. So in this case, the one at, the second one, the Doctors Hospital at Renaissance, that's the main hospital. There were 22 inpatient admissions, that's the IP. And then we have the Doctors Hospital at Renaissance with 1 claimant. that is the Women's Center. And then at the bottom, we have the Doctor's Hospital at Renaissance, and that is a day surgery. And we know sometimes they might keep a member, a patient in the hospital for observation overnight. Once it is kept, even if it's just overnight, that is considered an inpatient, and that is the reason that we have those in here. There were 2 inpatient admissions on an outpatient facility. That's what it's designated. Then we give you in there the Cumberland Surgical Hospital. That's in Dallas, and that's an orthopedic surgical facility that specializes in hip, knee surgeries, and back surgery. Okay, that's what they specialize in. Like I said, they're in Dallas. Then we have that Windmill Wellness that is in Canyon Lake, somewhere around closer to Austin than to San Antonio. And that it's a rehab facility to heal your mind. Any questions? Okay. We go to the top outpatient facilities, and in here, again, Doctor's Hospital. It's on top by 1,158 and paid $745, followed by McAllen Hospital, and then MD Anderson, the University of Southwestern, it's in Dallas, and that is also for a specialty clinical transplants. Then the biomedical, it is a dialysis center. Also, they have facilities in Dallas, Galveston, and Cedar Park. I didn't find any local, but those are the hospitals that we have. Any questions? Your top professional providers, and it's no surprise that the top one is the Texas Oncology. That is for your neoplasm patients, members, followed by McAllen Preventive Care Institute, that's PCI, then the Quest Diagnostic Innovative Infusion, and they do provide, they're out of Dallas also, and but they do cover all over Texas, and it's for infusion services. Livongo, remember we're talking, so we do have the participation and how much is being paid and how much is costing you for per visit per member per month, and that is for your diabetics. Then we have that Celadon therapy that it's anywhere between occupational for children all the way speech therapy, all that. The physician referral services, that's just, when members cannot find a doctor, they do have doctors they call the 1-800 number. Any questions?
Any questions, board?
This
Nope.
concludes my presentation, and we will have the annual review, hopefully, very soon. No, and I'm going to be just letting you know, so as to why it might be a delay. Our report runs 30 days, lacks 30 days, and they're available on the following month, on the 15th. On an annual review, we prefer it's, to wait that 2 months so we can capture as many claims that were incurred prior, to the end of the period, which is December the 31st. We like to wait those 2 months, and then we present in April, usually late March or early April. That's when we present our annual review. Yes, sir.
Oh, and I know your numbers, you just explained where your numbers go through, but we've recently, community's gone through a significant flu outbreak, and now it started back in September, October, and even now, but now RSV has kicked up. Have you all seen or discussed any uptick in claims in those last couple of months that may impact our numbers for the end of the year, for the fourth quarter?
Still not reflecting those, but we have seen an increase on vaccination, but it's not just necessarily because this October, that's when they start, either September or October starts, the pharmacies promoting the flu, and a lot of people that's getting it to prevent.
I just wondered if in treatment-wise, if you all had discussed within your company any significant increases, even if it's anecdotally, I was just wondering if, no?
No. We
Because
have
I mean, it
not.
was significant.
Yeah.
We've gone through September, October, now November.
Yeah. I will make sure we checked, and
Please.
we'll get you information on that.
Trustee Alvarado?
Just a quick, are we, anybody has some questions? Go ahead.
Can you talk in your mic?
Livongo Health, is that like a virtual thing?
It is a virtual thing. Yes, it is.
And the DL Stinson, is that a clinic in Mission?
Yes.
Oh, okay, I'm sorry. I thought they-
That's not PCI though, that's different from?
Dr. Stinson used to be at PCI, then he detached from them and he opened, and it's called the Wellness Center, and it's off Mission, Old 83, and that's where he has his facility.
And
Yes.
did people go there instead of PCI because he does like the MRIs and stuff like that PCI used to do and they stopped, or?
I think, is PCI no longer doing MRIs? Not to my
They
knowledge. I don't know. I don't know. Is PCI?
They have another office that they send you to for it.
Oh, they, okay, because he used to do them there.
So PCI hasn't changed their model.
Okay.
I think the reason we're seeing some utilization at the Mission for Dr. Stinson, some of the employees did actually follow him, and he did enter into a contract with Blue Cross similarly to PCI, so there's an incentive for the employee to go to that facility almost as good as it was to go to PCI locally. The copay is $5 at PCI, it's $10 at Dr. Stinson, so it's still better than our standard $20 copay.
Okay.
And just to follow up on that, I know PCI closed at 6. I've been saying we don't have there's a lot of night clinics out there, but it's full copay. It would be nice to have the same similar deal with some of these other ones, McAllen Primary, some of the other ones that are open every day of the year, even on holidays, because teachers don't like to miss. And so if they can go to a doctor on Saturday and have their copay waived, or Sunday, they'll go, and it'll save us a little bit of money because they can get medication, what have you, and we don't have to pay for a sub. So I still say that PCI closed at 6, and it's hard for a teacher on the north side to get to that before they close. And I know Dr. Stinson has a little extended hours, but it's still not truly a night clinic. So we need to please have the same deal that we have with PCI and other, because it does drive business. You go over there at dinner day, and it's all McAllen ISD because they save $20. But if we could do that and not have these guys go to a freestanding hospital because they don't know the difference, and we can publicize it, I bet we'll save some money. And I've been saying it for years, and while I'm outside because I had a conflict, I couldn't say anything. I don't have a conflict, so I'm gonna keep saying it. I'd like to see us expand that night clinic. Put it for RFP. You have tons of people, and I have no vested interest in them. They tell me all the time, if there's an RFP for a night clinic, I will put my name out there, especially on holidays. I mean, where can you go? There's very few, but they're open. But anyway, I'll get off my soapbox on that.
I know, but I appreciate that feedback, and if you have those names, if you could send them to me, because we've done several RFPs, and unfortunately, the response just wasn't there. Now, we've stopped doing them, but that doesn't mean we can't gear up and do another one.
Yeah, there's even some pediatricians. I mean, I would think Ashley would be pediatrics, Aguilar, I should probably say names.
Yeah, let's
Yeah.
refrain from that.
Yeah. I do have a question, so for you, sir, and it's related to our plan, just clarification. And so I know I got asked, because we made the switch, if you have a qualifying insurance and you're added to, like me, my wife's a teacher, I'm not employed with the district, and I have a qualifying insurance with my work. If I want to remain on McAllen ISD, I have to pay an extra $100 for on top of the family plan as to stay in McAllen ISD, correct?
So yes, and just to make sure I understood, you're referring to our new spousal surcharge.
Right.
And so yes, but just to be clear, it's the eligibility, it's for a spouse who's enrolled as of 1/1, and that spouse has the opportunity to enroll with their employer. So if they're not employed, self-employed, it doesn't apply. It's only if the spouse is employed and they have an opportunity to enroll with their employer, regardless whether they enroll or not, as long as they have the opportunity.
Can you give me a good 30-second reason why we do that, and that's to help me? I know why we do it, but I try to explain to someone and I lost in the weeds, so.
Sure.
If someone calls you and they're complaining, why are you doing this? What are you telling them?
So try first of all to explain to them that we're a self-funded organization. So, you know, we're all in this together, and so we try and definitely keep the costs for employees down. And so it is tough when other employers are technically not taking on the liability for their own employees because our plan has richer benefits and or lower costs.
It does.
And so, you know, families make the decision, financial decision, obviously, to enroll in our plan. So that increases our liability and our risk. So if those particular spouses are incurring more claims, then all our costs go up, and then we have to consider, obviously, increases in premiums and or reduction in benefits.
I try to say that, but I didn't say it as well.
I don't know if that was 30 seconds or not.
But I'm gonna have to call you, that's what I was thinking when you were talking. Good job, thank you.
Thank you.
Thank you.
All right. Any further questions? Pat, Chris, from Mariah, and Ita, Cindy, and Hoey, we appreciate you guys from Blue Cross Blue Shield coming out today.
Thank you. May
Without
I?
any further questions,
she's
can I
got
get,
some.
oh, sorry, Ita.
On the presentation, since this was our first to the board, it's a work in progress. If there's anything that you would like to see less or you would like to see more, please let us know. You know, you have, you know, and we'll be glad to continue drafting.
The dialogue is good because if there's any trends, like Trustee Bella was saying, we can get ahead of it. We know now that, you know, we're okay in certain things, and so instead of waiting, so it was great, so thank you.
Thank you.
All right. Without any further ado, can I get a motion to adjourn?
So moved.
I have a motion to adjourn. Is there a second?
Second.
Thank you. I have a motion by trustee Alvarado and a second by trustee Peña. All in favor signify by saying aye.
Hi.
At 6:52, our meeting is adjourned.